So we'll go ahead and get started. Thanks everybody for joining us. I'm David Lamb. I'm Director of the Institute for Social Research at the University of Michigan. Very glad you could all join us today for this fourth installment in our ISR Insight speaker series. Great to have you all with us. For those of you who are unfamiliar with ISR, we have faculty and staff conducting research on a wide range of topics, including wealth and inequality, race and racism, aging and health, topics that you're going to hear about today, and many other topics, including teen drug use, economic behavior, and politics. We have over 300 affiliated faculty, including faculty from almost every school and college at the University of Michigan, a reflection of the very interdisciplinary nature of our work. The goal of this ISR Insights speaker series is to have a forum for disseminating research findings of our faculty at ISR. So far, we've had 3 fantastic sessions. First was on the educational achievement gap during COVID-19. We had one on the results from the Detroit metro areas community study, looking at the impact of COVID-19 on Detroit areas. And we had a great presentation by Fabian Pfeffer, who recently launched the Center for Inequality Dynamics at ISR, speaking about wealth inequality across the generations for whites and blacks. All of the recordings of those events, as will be true for the event today, are posted on the ISR website, isr.umich.edu. And you can find information on upcoming talks there, as well as on our social media channels. We have a number of excellent talks coming up in the coming weeks. For today, I'm very happy to have the pleasure of introducing our 2 excellent speakers. Jessica Finlay is a Postdoctoral Research Fellow in the Social Environment and Health Program in the Survey Research Center here at ISR. Lindsay Kobayashi is Assistant Professor in the Center for Social Epidemiology and Public Health and Population Health at the university's School of Public Health. They're going to be talking about their COVID-19 coping study of older Americans. COVID-19 has both immediate and long-term consequences for the health and well-being of Americans, with older adults being at higher risk not only from severe illness from the disease, but also being vulnerable to social and emotional harms associated with the pandemic. In our ISR Insights talk today, Lindsay and Jessica are going to talk about the insights from their COVID-19 coping study of nearly 7,000 adults age 55 and over from across the country. The talk will share the participants' perspectives and diverse experiences during the first upswing of the pandemic, including major sources of stress and ways of coping. A couple of housekeeping details. We have live captioning. You can turn it on using the CC Live transcript button and choose the show subtitles at the bottom of your screen. We also have a Q&A at the end of the presentation, so please send in questions during the talk. Feel free to send them in as they come up using the Q&A feature of Zoom. And at the end of the presentation, we'll try to have the speakers get to answer as many questions as they can. So thank you very much for joining us today, and I'll turn it over to Lindsay and Jessica.
Okay, thank you very much for that wonderful introduction, David. I'm Lindsay Kobayashi, and Jessica Finlay and I are really excited to share with you the methodology, our recruitment, and some of the baseline descriptive results from the COVID-19 coping study, which is a longitudinal online mixed methods study that aims to understand mental health and well-being among older adults during the COVID-19 pandemic. And as a little bit of background, Dr. Finlay and I have been collaborating together for a few years now on issues around social isolation, loneliness, and health in older adults, primarily using mixed methodologies using both quantitative and qualitative data. And this is really founded in each of our research programs, whereby I'm an epidemiologist. I use epidemiologic methods to study health in older adults, primarily using large population-based cohort studies such as the Health and Retirement Study. And Dr. Finlay primarily uses qualitative as well as mixed methodologies to try to get at more in-depth and nuanced variations and responses in health among older adults. And in our previous work on aging, we've observed that social isolation and loneliness are highly prevalent in older adults and related to a range of adverse mental health and well-being outcomes. And there's a really robust literature that demonstrates this as well. And as the COVID-19 pandemic was really taking off in the United States in early March, we very quickly realized that there were going to be a lot of really indirect population health consequences of the pandemic. So not just morbidity and mortality that are directly due to the virus itself. And so with this in mind, and with our focus on aging and gerontology and our shared research, we launched the COVID-19 coping study, beginning to plan it in the middle of March, and we went into the field in early April. And we'll give more details on that methodology in the coming slides. But as a little bit more background about aging, older adults, and COVID-19, again, I think as we all know, the COVID-19 pandemic is creating a really broad public health crisis that is extending beyond direct illness and mortality due to the virus. And to explain this, I've been talking about the COVID-19 pandemic using an analogy that the pandemic is sort of like an onion. And so the outer layer of this onion, which is what is directly visible and sort of the most immediate, of course, are cases of COVID-19 illness due to infection with the SARS-CoV-2 virus, as well as mortality due to the virus. And of course, this is an urgent public health and clinical priority that we are all working very hard on. I also think that once we start to peel back that outer layer of the onion, which are these like direct cases of COVID-19 and causes of death due to COVID-19, we start to see the indirect effects on population health of the pandemic. And these are really broad and complex. So for example, things like avoiding accessing healthcare services because of fear of exposure to the virus, things like the potential negative health effects of social isolation and physical distancing, which we will talk about a little bit more. And again, we know that social isolation does have, or is associated with a range of negative health outcomes, including cognitive decline and dementia, cardiovascular health outcomes, as well as increased risk of all-cause mortality. Another serious concern are the population health effects of the deep economic recession that the United States has now found itself in. We know from previous literature and previous recessions that they do have really widespread population health consequences, namely, I think, mental health outcomes and increased rates of suicide during economic recessions. And this is an indirect cause of population morbidity and mortality that we really do need to be focusing on as well. And finally, it's also very clear that the COVID-19 pandemic is really exacerbating and shedding a lot of light on existing racial and socioeconomic inequities in health in the population. We know the pandemic is not having equal consequences across the US population, with very, very severe racial and ethnic inequities in illness and mortality due to the virus. And this is likely to be true as well for many of these indirect causes of morbidity and mortality as well. And so with all of this in mind, we aim to ask the research question, what are the effects of these complex and changing social and economic circumstances as a result of the COVID-19 pandemic on the mental health and well-being of older adults? And this is actually really, really important to understanding, to controlling COVID-19. And this is because older adults may be particularly vulnerable to severe illness from being infected with COVID-19, as well as increased risk of mortality due to COVID-19. And so older adults may need to physically distance or shelter in place more intensely and for longer than younger population groups in order to minimize the population health burden of COVID-19. Another issue is the economic effects. So older adults who are still engaged in the labor force, either beyond retirement age or leading up to retirement age, may be particularly vulnerable to financial harms. And if a job is lost or work hours are lost, may never have the opportunity to enter the labor force again. So we may be seeing issues around financial insecurity due to early retirement. And so one thing that we really need to do is find ways to best support older adults' mental health and well-being throughout the stress of living through the pandemic, and to support them through sheltering in place as well as economically in order to minimize the population health effects of the pandemic. And so specifically, what the COVID-19 coping study aims to do is to investigate dynamic changes in older adults' experiences, perspectives, daily activities, coping strategies, mental health and well-being during the pandemic, and to identify risk and resilience factors that influence mental health and well-being during the pandemic.
So the study is a longitudinal mixed method study of people aged 55 and older who are currently living in the United States, and that can include Puerto Rico and Guam. And they needed to be able to complete the online questionnaire in either English or Spanish. And for age, we are aware that many people do not self-identify as an older person at 55. And we've heard, for example, from participants in the study who mentioned that they themselves consider themselves to be, late middle-aged, and their parents, who are 80 or 90 years old, to be older. And Dr. Kobayashi and I consider aging to be a lifelong process. And so we hope that this study captures a range of aging experiences and perspectives that can span from late middle life to end of life. We also recognize that people feel older at different ages. In previous research I've done, for example, people have told me, I'm not going to live to see 65. And this can be particularly common amongst those who are socioeconomically marginalized as well as vulnerable. And so given that aging populations are incredibly diverse, we're extending that age range down to 55 to better study these differences. And so in order to recruit diverse older adults into the study, we know that we wanted to have a really rapid kind of recruitment strategy. And so given that the first upswing of the COVID-19 pandemic in the United States happened fast, with rapid changes in virus transmission rates, government responses and fluid socioeconomic conditions, we used an online multi-frame snowball recruitment strategy. And so what this means is we had multiple ways of trying to recruit participants. And this included social media ads, for example, on Facebook and Instagram, emailing on organizational mailing lists, as well as contacting news outlets such as radio, newspaper, and television. We also recruited participants from 2 research databases, one, the NIH Research Match, and the other, U of M, University of Michigan Health Research Database. We also employed word of mouth, which was an important strategy for those who might not have otherwise heard about the study, such as those not frequently online. And this really helped to expand our scope of participants. We also employed a professional survey company to recruit 2,500 participants. This was in part to increase our sampling size, but we also set quotas in this group for age, gender, race, ethnicity, and education to match the general US population age 55 plus. And we were really pleased that we really received a really enthusiastic and quick response. We rapidly met and then exceeded our target size. And so we were open for new participants from April 2nd to May 31st, 2020. The first step of the study was a 20-minute online baseline questionnaire that was hosted on the platform called Qualtrics. And this included questions that asked about sociodemographic information, such as age, gender, race, ethnicity, and zip code. We asked about pre-COVID employment and income loss due to COVID-19, as well as COVID-19 symptom and testing history for participants themselves, as well as their family members and close friends. We asked for self-reported physical health and memory. We also asked for physician-diagnosed health conditions and included mental health scales for isolation, loneliness, depression, and anxiety. For physical distancing practices, we asked about, for example, how many days in the past week have you spent at home, only leaving for essential purposes, such as groceries and medical care. We asked about changes to daily life during the pandemic, as well as health behaviors such as exercise and alcohol consumption. We asked open-ended questions about specific worries and stressors, and also ways of coping with those stresses and worries. As we've mentioned a couple times now, this is a longitudinal mixed method study. So we're aiming to investigate the secondary health effects related to social, behavioral, and economic impacts of COVID-19 over time. And so we're sending out monthly follow-up questionnaires that take about 10 minutes to all Snowball participants. And these questions continue to track COVID-19 testing and symptoms amongst participants and their close family and friends, as well as changes to behavior in daily life throughout the pandemic, and people's experiences and perspectives over time. We can also see whether there are any changes within people to their physical and mental health over this period. And then beginning in October of 2020, so about 6 months after the survey was first launched online, we'll ask a representative subsample of 100 participants to complete a 45-minute telephone interview or also by secure video call. And these will be semi-structured interviews where participants can share their experiences and perspectives more in depth. And so we'll ask for personal stories, reaction to public health policies, and perceived sources of risk and resiliency throughout the COVID-19 pandemic.
So ultimately, we recruited just under 7,000 participants into the COVID-19 coping study in the months of April and May. About 4,500 of these people came in through our snowballed recruitment strategy, and 2,500 came in from the professional survey company. And the map on this slide shows the distribution of respondents across the United States. We had really good response nationwide. We had respondents from all 50 states and the District of Columbia, as well as Puerto Rico. And in the next few slides coming up, I'd like to show just some of the basic sociodemographic distributions of our study sample. So the lower end of the age range, again, was 55 years. About 40% of the sample were aged 55 to 64. And as well as 65 to 74. 17% of the sample was aged 75 and older. The mean age was 67 years and the standard deviation was just over 7 years. 36% of the sample was male and 64% were female. About 88% of the sample reported that they were white, 6% reported that they were Black or African American, 3% were of an Asian background, and then less than 1% were of other self-reported racial backgrounds. These are not mutually exclusive categories here, so it sums to more than 100%. And there are 306 respondents who reported that they were Hispanic or Latinx, regardless of their race. With respect to education, 17% had a high school diploma or less, and 35%, so just over 1/3, had a postgraduate or professional degree. With respect to living situation, 26% or 1 in 4 participants lived alone, and this is roughly in line with what we see with national data on the older population in the United States. And about half the sample was retired prior to the COVID-19 pandemic, and half was still engaged in the labor force. Really briefly, I want to show some of the self-reported economic impacts of the COVID-19 pandemic within the sample. Again, this is at baseline between April and May. We asked this question among those who were who reported that they were not retired prior to the pandemic, and if they had any recent effects on their employment. And so 5% of those who were still engaged in the labor force had lost their job, 15% were furloughed, 22% reported having lost work hours or income, 43% now working from home, and only about 20% of people had their work not being affected by COVID-19. So we see really profound effects on employment, with over 40% of the sample losing employment hours, income, or their job in some way.
We asked participants, how worried are you about COVID-19? And about 2/3 were either moderately or extremely worried, and less than 1% were not at all worried. For COVID-19 symptom and testing history, at this baseline questionnaire, so again, in April to May of 2020, 0.5% reported testing positive for COVID-19, and 9% reported having symptoms but not being tested. 12% had at least one family member or close friend who had tested positive, and 13% had, again, at least one family member or close friend who had symptoms but had not been tested. Nearly 3/4 of participants had self-isolated every day in the past week, so only leaving their residences for essential purposes such as work, obtaining food, medications or other supplies, outdoor exercise, or taking care of pets. And the open-ended questions really shed some insight about people's experiences during this time. And for example, one major theme that came across in the open-ended responses was family dynamics while sheltering in place at home. And for some, it presented an opportunity to connect and spend more time with family members. For example, one participant wrote, "I secretly loved having my 2 adult children staying with me during this time. We have really bonded again." For others, it could cause conflict, strife, and anxiety. For example, in this quote, someone wrote, "Living with adult children during COVID-19 is very stressful. Battle over control within the household."
And as our primary study outcomes are mental health, we want to show here some of the distributions of the outcome scales at baseline. So 32% of the sample screened positive for depression on the 8-item Center for Epidemiologic Studies depression scale, or CESD. This was defined as scoring 3 or greater. 11%, so about 1 in 10, screened positive for anxiety on the 5-item Beck Anxiety Inventory, which assesses some real, relatively severe clinical symptoms of anxiety. And then 28%, so again, almost 1 in 3 participants screened positive for loneliness on the 3-item UCLA Loneliness Scale, which is a widely used research scale to assess loneliness. And I think that one of the important things here, we are seeing higher prevalence within our specific sample of these symptoms, according to these scales, which are used quite frequently in research among older adults. And I think one thing that we'll need to dig into in the longitudinal data, and I think one of the valuable things that this study adds, is whether or not these are really sort of transient increases. Well, I don't want to say increases, transient, proportions of screening positive on these scales, and whether it will sort of go away as people adapt to life during the pandemic. You know, I think it's natural to feel sad and to feel lonely given everything that is going on, and you know, people really are isolated. And so I think distinguishing between what is just kind of like a natural emotional response that is not necessarily indicative of a clinical syndrome versus whether this is actually an indicator of more severe population, potentially population-wide increase in clinical expressions of depression and anxiety is really important to distinguish between. And so tracking the longitudinal within-person changes over time on these symptom scales will be really important within this sample. And again, the qualitative quotes that people gave us in the open-ended responses on the questionnaire really give us a lot of depth and insight onto what we see in these mental health symptom scales. And so we've pulled a couple exemplary quotes here. And again, what we're showing with these qualitative quotes is not a full qualitative thematic analysis, but just a few exemplary quotes that have come through in the responses that we've seen so far. So one respondent reported, "Even though my life is stable and I'm staying at home with a spouse I get along well with, I'm surprised at how the situation has amplified anxiety and depression that I thought I had under control." And another respondent reporting, "I've discovered my inner hermit. Fear I may have trouble relating when back in the real world." We also assessed causes of worry and stress in our sample, and so we asked one of the quantitative questions in the questionnaire was asking about significant sources of worry or stress, which we defined as things that are either constantly on people's mind or keeping them up awake at night. Really briefly, we want to show a snapshot here of the top 5 things that respondents reported. The number 1 source of worry was having family members or friends becoming ill from COVID-19, catching the COVID-19 virus themselves, or becoming seriously ill from COVID-19, followed by retirement savings and future plans. And again, the qualitative quotes that we recorded in the open-ended responses, again, shed some light and depth on these really brief survey questions that we had. So for example, being recently diagnosed with cancer has made this much more difficult. Testing was delayed by 8 weeks due to COVID-19, which added stress. And we really did see a lot coming through in the open-ended responses with respect to ongoing health conditions and how the COVID-19 pandemic has sort of exacerbated management for existing conditions. Another one was caregiving. So caregiving for my 96-year-old father is much more challenging as he does not understand current public health restrictions. We have a number of quantitative caregiving questions in our study, as well as we did see this come through in the qualitative data. So I think that this will provide some really valuable mixed methods results, because I think that caregiving has become a major challenge for a lot of families during COVID-19. And finally, economic stressors was a main thing that came through both in the quantitative question about stresses as well as the open-ended responses. And this was one that was kind of difficult to get into, where one respondent said, "My economic life was evaporating before my eyes and I could do nothing. My most infirm years ahead were looking bleaker with each financial shock. I can only hope my children love me enough."
And in addition to these stressors and really kind of difficult everyday conditions in these times, participants also shared the ways of handling these challenges, worries, and stressors. And so one of the mixed methods papers we're currently working on focuses on these diverse ways of coping amongst respondents. And we'll just share some of those main themes that came across right now. So for example, at-home projects were a major source of kind of keeping busy and trying to cope with it. Things like spring cleaning and organizing, cooking and baking. People wrote to us that they're writing more, engaging in arts and crafts, doing things like woodworking, puzzles, knitting and crocheting, and also playing instruments. Many also wrote about trying to keep and maintain and kind of improve even their daily patterns and routines. So things like keeping busy, staying informed, reading books, watching shows and movies, listening to music and podcasts, and also trying to eat better and prioritize sleep. And also, many shared that they were trying to get outside more while being still distant from others to be safe, with activities such as walking, biking, and jogging, and also doing yoga. And many mentioned faith as a source of hope and kind of stability in this time. And they wrote to us about how they found solace through prayer, reading scripture, and watching or participating in faith services. People also commonly talked about adhering to physical distancing and public health recommended practices. And this includes wearing a mask and gloves, staying home, maintaining at least 6 feet of distance from others, and also grocery shopping via family members or online if their own health made it difficult or worrisome to do grocery shopping themselves. And for mental health, participants wrote about engaging with mental health professionals as well as support groups, and also either continuing to take, newly taking, or increasing their intake of anti-anxiety and depression medication as directed by healthcare professionals. Many participants also discussed ways of trying to adjust their attitude and outlook throughout this pandemic. And this included practicing meditation and mindfulness, doing breathing exercises, trying to reframe their expectations and stay positive, to acknowledge what they're grateful for, and accept feelings about the situation. And many also wrote about trying to seek out laughter and humor and lightness in some of these dark days that they faced. Participants also wrote to us about civic engagement. So activities like making masks for others, donating to causes, helping others such as family members, friends, neighbors, and broader people in their communities, as well as volunteering on political campaigns and contacting elected officials. And one of the major overarching themes that came across in responses was social engagement as a way of coping. And so this included reaching out to, communicating with, and trying to support family, friends, neighbors, and those in their community, whether that was online or by phone, or in-person time was spent with people. And I would just say again that we're learning so much from these kind of open-ended responses, and we're very grateful to the participants who have spent a lot of time and effort and care to share with us. And we're very privileged to be a part of this. And just a couple more quotes to share with you that really have captured our attention and our thoughts in this time. So one participant wrote, for example, I have made over 400 face masks / coverings for healthcare professionals or frontline responders, friends, and neighbors. This has given me a purpose during this pandemic and something to do instead of cleaning my garage. Another person wrote to us, along the lines of mindfulness, I remind myself how lucky I am to have shelter, food, and friends. I remind myself to concentrate on only that which is in front of me and which I can control. I remind myself often that this won't last forever.
And so what are our next steps? In addition to the data analysis and preparation of manuscripts that we're working on right now, our monthly follow-ups are ongoing. So we closed our 1-month follow-up at the end of June. Our 2-month follow-up will be closing at the end of July. And again, the follow-ups are happening within the 4,500 participant Snowball sample, not with the professional survey company. And about 95% of individuals in the Snowball sample consented to take part in the monthly follow-ups and provided an email address for us to send the follow-ups to. Based on the follow-ups that we've done so far, the response rate is around 67%, so 2 in 3 people that we reach out to, which is pretty good for an online study. So those are ongoing, and they will be going again for 1 year until May 2021. As Jessica said early in the presentation, we will be conducting semi-structured in-depth telephone interviews this fall, and then we will also be making our data publicly available through archiving at ICPSR. And then we just also wanted to give an overview of some of the ongoing planned analyses that are happening right now. And so again, our primary study outcomes are mental health and well-being. We are looking, of course, at social isolation, physical distancing behaviors, and living alone and how these relate to mental health, as well as support networks, family dynamics, and online connections. And I think this is actually really important because I think, things like telephone calls, Zoom, FaceTime, other forms of virtual social connections are really being promoted right now. But I think we actually don't know very much about whether virtual and non-face-to-face social connections can really be a substitute for in-person social support and social connection, at least with respect to health outcomes. So one of the analyses we're working on right now is how the relationship between isolation, physical social isolation, and mental health, and whether actually having these online virtual connections can sort of buffer any potential negative mental health effects of physical social isolation. Because we have geographic identifiers in our data set, we can look at a lot of area level contextual factors, which again is really, really important because we see so much heterogeneity across the country with respect to what's happening with the pandemic. So we can look at things like the local COVID-19 burden, so incidence and mortality rates in people's local area with respect to mental health, as well as contextual factors such as area level poverty, racial residential segregation, availability of things like parks and green space, and how that relates to mental health. In addition, we can also look at various COVID-19 policies that have varied over time and place, such as level of reopening. Changes in behavior, so things like exercise, alcohol, both positive and negative coping type behaviors, how are those changing over time, and how do those relate to mental health and well-being? And then, of course, as I mentioned earlier, looking at these longitudinal within-person changes in both physical and mental health will be really important in this study and something that we can really add a lot of insight into. And finally, our public engagement strategy involves doing things like public talks, just like this one, as well as media. We've done a few podcasts and we hope to engage in more. We're doing a monthly newsletter with our study participants. So we're providing results of the study back to them as well as resources for coping. We also have a study website that has information, including our study questionnaire has been made publicly available on our website. And ultimately, we really hope that the results of this study may be useful for policymaking with respect to supporting mental health and well-being of older adults throughout the pandemic. And finally, we just want to thank and acknowledge our wonderful study team, Marissa Eastman, Jasdeep Clare, Brendan O'Shea, and Yamani Vincent, who have put countless hours into this study along with us, as well as our collaborators, Rafael Nishimura and Caroline Pallavicino Maggio. And most importantly, we would like to thank and acknowledge the study participants for taking time out of their lives to take part in our study. And we would like to also thank ISR for having us for this Insights Speaker series. And finally, if you want some more information, you can contact us at our email addresses here or go to our study website. I'm going to skip ahead one slide because the same information is here as well, in addition to the ISR website. And so I think we've got lots of time for questions and discussion right now. I see some questions coming in on the Q&A, and I think there's a lot of different things to dig into, so we hope we can answer everyone's questions.
Yeah, I can get us started with the question.
Okay, so there's a few questions here. Where should we start, Jessica? I think let's take this question, if that's okay, Jessica, let's take this question from Grace Ridings, who asks, what are the implications of the study not being representative of the US general population? And I think this is something that's really important that we need to talk about, especially with making the data publicly available. And so this is a non-representative sample. And I think that this is something that we thought really deeply and carefully about before we launched the study. I think to obtain a nationally representative sample during the COVID-19 COVID-19 pandemic, when face-to-face human interactions were just not feasible, and also under resource constraints was just not really possible. So we used an online methodology. And so we know, as you saw in the demographics that I presented early on, women, white, older adults, and educated people are overrepresented in our sample. And this is true in the literature of research that uses online or internet-based recruitment strategies. And so the one thing I would say is our study is absolutely not designed to estimate or generate population representative prevalence or incidence estimates of the outcomes we're looking at. And so for anyone who uses the data, once it's been made publicly available, I would actively discourage using it for that purpose. But what the study can do is provide inferential estimates of specific exposure outcome relationships. And so the degree to which the sample is non-representative in that case depends on whether we think that selection or participation in the study is going to influence a specific exposure outcome relationship that one is interested in. And so we don't need to get like too deep into the methodology here, but I think it's an issue of like whether or not we think there is selection bias in our sample relative to the general population. So for some research questions, it may not matter, but for others, it might. And one of the things that we're doing right now, and this is specifically in collaboration with Raphael Nishimura, is we're making post-stratification weights based on the mental health outcomes using demographic information from the American Community Survey, which should help minimize that. And then I suppose the final thing that I would say is that I would say that the study is potentially not generalizable to non-internet users, even though the prevalence of internet use is actually relatively high among older adults, if we think that the associations under study differ between internet users and non-internet users. And so I think it's an interesting methodological thing as well.
All right. We have a next question. This one is from Robert. It is, do you have any contextual data covering the neighborhoods where respondents live? For example, proximity to parks, open space, etc. And as a geographer, I love this question. It's absolutely something that we're planning to do. So we have the zip code where participants lived, and we'll be matching that to NANDA. It's the National Neighborhood Data Archive, and it's hosted by ICPSR as well. Feel free to send me an email if you have any questions about that. But we are planning to look at whether, for example, living close to green and blue space, so having lots of trees or open water nearby, is that related at all to people's behaviors and perceptions? We also have some wonderful quotes about people describing their neighborhoods as well, so we can compare the perceived reality of your neighborhood to where people are actually living. So we can look at things like, do you live close to healthcare, to coffee shops or food services, grocery stores? So we will be comparing, we will be matching up the data based upon the geographic coordinates that we have for all participants, and to look at kind of whether the places you live might have any impact on your experiences to support or also put you at risk given your personal living situation.
Thanks, Jessica. I'll take the next one if that's okay. And I think there were two people who seemed to have a similar question. So Muniba Salim asks, I may have missed this, but are you examining differences in racial ethnic groups with respect to COVID coping and mental health outcomes? And Leah Abrams has a similar question asking, she had two questions. I'll give her a second question and then come back to the first. The second one being, have you looked at differences in mental health / coping by race given the protests and unrest in May and June? And so yes, we are planning to look at disparities in coping and mental health outcomes. I definitely think there are multiple contextual things that happened during our data collection, both with respect to the incidence and distribution of the COVID-19 illness, as well as things that happened after the murder of George Floyd and subsequent protests in the US. I think that's really important. I wish we had a larger sample size of non-white participants. I hope we have sufficient statistical power. We will look at it, but I would also like to see results from other studies as well that we can compare our findings to. And then one more final thing related to the protests and unrest in May and June. If you don't mind, Jessica, I'm going to merge into a third person who asked about that, Stuart Arnold, who said, did you see changes as the months went on? In my case, I started out pretty positive, but the negativity of the presidential campaign and the George Floyd murder have turned me much more negative and anxious. And I think that's definitely true. I mean, I think we are all feeling a lot of tension and grief and upset related to that. And I will say that we have not started analyzing, like seriously analyzing our longitudinal follow-up data yet, but in a very preliminary sense, in the open-ended survey questions that started in early June, which again was shortly after the murder of George Floyd, we saw a lot of responses coming in related to reactions and attitudes and upset and stress and grief related to what happened and has been happening. And so I think we will have some either qualitative or mixed methods work coming out looking at changes in mental health after and as affected by the murder of George Floyd and other police violence that has happened across the country and subsequent protests.
All right, thank you, Lindsay. Another question we have is, how is this study funded, and are you accepting philanthropic support? And so our study is currently unfunded, and so we are actively seeking funding to help extend and continue this study. But we currently are kind of on a bootstraps budget, and so we've done as much as we can given our limited funding, but are still seeking other sources of support. And so that will include more formal organizations at the governmental level, as well as philanthropic organizations who are interested in these topics of the health and well-being of older Americans throughout the COVID-19 pandemic.
Thanks, Jessica. And now I want to address the first part of Leah Abrams' question, which was, have you examined rates of death of a loved one and implications for grief? We've not analyzed that yet, but I think we definitely have the data there and the capability to analyze it. I think that, to be honest, we have more data than we have capacity within our team to analyze and publish on. And we really want this study to be for the public good and to be made available to other researchers. So we did try to capture a lot of different things in our survey for future work. And so, like, Leah, seriously, if you do want to look at this, email us. And I think that that would be a really valuable thing to get out of this paper, because I think that we are absolutely going to see increases in grief and potentially at least short-term mental health outcomes associated with death of a loved one. That would be my hypothesis, but I think that we definitely can look at it.
Yeah, and I would just add on to what Lindsay answered, that we have asked about grief and sadness as a qualitative open-ended question. And again, we haven't yet had a chance to analyze this data. It was in the field just recently, so we're still collecting a few final responses. But we have received very thoughtful and intimate responses from people given loss of loved ones throughout this time, not just directly from COVID-19, but what I kind of have called adjacent mortality. So people who didn't go into the hospital because they were concerned about contracting COVID or just didn't want to be a burden on the healthcare system. And as a result, they did wait until a later time, and they were so unwell by the time they got into the hospital that they did either have a prolonged hospital stay or also severe illness or death from that. So we have, I would just say anecdotally, we have heard many people sharing experiences of grief and sadness throughout this time, directly from COVID-19, as well as all of the other kind of complicated, as Lindsay mentioned, those other layers of the onion. Many people are having a lot of struggles that they are sharing with us in the qualitative responses, as well as the quantitative questions that we have answered every month.
For the next question, I'm going to take another methodological one, if that's okay. These are my favorite. So Grace Ridings again asks, how do you account for the non-random snowball sampling in your statistical analyses? This is super interesting. So this study is really, for me at least, the first time that I've used a non-random sample or used the word of mouth snowball sampling. I think this was actually a really useful and important technique that we employed, because it enabled us to, what we really aimed to do, because we knew it was going to be non-representative, we aimed to sort of triangulate and maximize our reach using as many different methodologies as possible to capture different segments of the population aged 55 and over. So using the word of mouth technique allowed us to reach people who otherwise would not have heard about the study, who don't use social media, or who are just online a little bit less. And we actually had like a non-negligible proportion of people in our study who reported that they never used social media. And this was actually one of the ways that we started seeding the survey when we were recruiting. So I think it was a valuable thing to do, but what it means is that the study really, for at least a segment of the population, sort of diffused through social networks. Which is really interesting. And I think what we ultimately will need to do is cluster standard errors because we do not have independent responses within like segments of the population. The level at which we cluster the standard errors we're working on right now. It might make sense to do it by zip code, even though I know there will be connections that kind of transcend like zip code level geographies. And then we can also do things like include fixed effects for state as well in our modeling.
This is just a quick question that says, will it be possible to get a copy of the slides presented? And yes, I know that this is being recorded and will be posted on ISR's website, so one can rewatch this and see the slides as well as us talking. We'll also put a PDF copy of just the slides on our website after this. So in the next few days, if you go to COVID-19copingstudy.com, we'll have a copy of these slides available for anyone to download and look at.
Thank you. And here's an interesting question from Leodin Solomon, who asked, did mobility/ability status impact analyses in any way? If not, is this something you feel could be a future direction for similar research? So we did ask about use of mobility aids. We asked about specific types of mobility aids and found about 10% of our sample used some form of mobility aid, whether it was a cane, a walker, an electric scooter, wheelchair, or other type of device. And so at least in the papers that I'm working on right now out of the baseline data, we've been treating that as a covariate in modeling. But I think anyone who's interested in disability and whether there might be heterogeneous effects of various exposures on mental health outcomes according to ability status is a really important question. Again, we are not seeing equal impacts of the pandemic across the population, and I think thinking about unequal effects or inequities in outcomes according to disability status is really important and not something that's gotten a ton of attention so far. So I do think that is something that would be an important future research direction.
Another question that we have here is, how could the study inform policymaking to support older adults during the pandemic? And I think that's a great question, and something we spend a lot of time thinking about is how can we translate these results into kind of actionable projects and priorities that might be used by policymakers and also just community stakeholders and other groups trying to support older adults through this time, given that we know older adults may have to isolate more intensely and for longer than other populations, for example. And so I think in part, as I said, this is kind of addressing the secondary health effects related to those kind of social, economic, and behavioral impacts of COVID-19. And so we can kind of identify adverse psychosocial consequences of these situations. And we know, for example, and we're seeing that social isolation and prolonged loneliness are really critical issues, and COVID is really intensifying this struggle for many older Americans. And so we can identify specific risk factors that may put older adults more at risk for poor mental health that maybe could be identified and targeted in public health strategies, as well as sources of resiliency and strength. So, for example, I shared some of those coping strategies. Perhaps those can be folded into community programs to support older adults. We can think through, for example, creative online social programs that may be able to kind of outreach and connect people. We've heard from participants, for example, who say, I'm alone but not lonely, given that they do have online social connections and creative ways of engaging and supporting with others, such as making masks or joining virtual support groups and online chat forums. So I think that the study kind of shows a multitude of both factors that put people at risk for poor mental health, but also ways of coping and being resilient and strong through these times that we can hopefully kind of turn into more formal policies to support older adults across the country. And then, like Lindsay mentioned, we can also look at specific groups because we know that this is not unfolding equally by person or by place across this country. So looking, for example, are there, particular area, neighborhood characteristics or residential segregation or other elements that we can maybe look to find those most at risk to provide support like telehealth services or other kind of online programs to support people that are really most at risk throughout this time.
Yeah, and one more thing to build on that is that the Centers for Medicare and Medicaid Services, or CMS, has expanded their telehealth mental health services early on in the pandemic, but that is set to expire at some point. And so I think we don't know the extent to which we need to be continuing those services, expanding them, if they need to be tailored or targeted to specific populations who may be experiencing a greater mental health burden. And so with the longitudinal data, kind of looking at the persistence of various mental health symptomologies is going to be really informative for understanding whether we need to recommend that potentially Medicare Services needs to keep these expanded telehealth services ongoing and not expired, and the best ways that they can be targeted.
Lindsay and Jessica, I have a question. I actually, as an organizer, I can't submit it through the written form, so I'm going to use my prerogative as chair to ask. You've got a lot of fascinating results here, and it made me wonder, as you've seen the results and as you've sort of seen the pandemic unfold, has it changed your feeling about what you're going to do in the follow-up? Is the follow-up sort of already developed? Are you seeing things that make you think about adapting that in some way? And generally, what do you plan to do in the follow-up?
Yeah, the follow-ups. Do you mind if I start, Jessica? And I'm sure you'll have other things that I miss. Yeah, so we have adapted and changed the follow-ups as time has gone on. And so we kind of knew when we launched the study, we kind of knew that things were going to change and we didn't know what life would look like in a few months. So we left the follow-ups a little bit open in a way. The one thing we are keeping consistent across every follow-up is the mental health symptom scales and self-rated health outcomes, as well as self-reported COVID symptom and testing history. So those things we definitely knew we wanted to keep consistent over time, but we did leave it open with anticipation that things would change. So the follow-ups we're in the process of designing our 4-month follow-up right now. So we have the 1, 2, 3 months have been in the field. We put a stronger economic focus in the 1 and 2 month follow-ups when it became clear how severe the economic recession and implications were. So we are asking people, we're done now, but we've been asking people about receipt of the personal stimulus check from the government as part of the stimulus package. We've asked more in-depth questions about effects on work and on income. Also, another thing that has been changing is living circumstances. So we're interested in kind of household dynamics and whether people are having potentially children moving in with them, whether they are moving out to other places and what that looks like. Also housing stability as well. I think the economic implications are going to keep going on. We've taken out the stimulus question now because those checks are pretty much mailed out. I could foresee that coming back in the future. What else, Jessica, have we changed?
We've also added new open-ended questions for every one of the follow-up questionnaires. So just last month, for example, we asked about attitudes towards reopening of businesses and the level of public health restrictions in your local area to see how people were responding to kind of what was happening at that time. We have asked questions about, for example, how it's impacting close relationships, given, as I mentioned, one of the themes that's coming across is these shifting family dynamics. So we're asking about people's experiences for that. And just in the 4-month, we're going to ask a question about how it might impact the identity and feel and activities of your neighborhood, given now that it's been a few months later. And then also, I think that for the telephone interviews that happen in a few months' time, we still don't know exactly what they'll focus on, given that we are still learning and listening as much as we can in this time to people's experiences. And it is really, in a way, we face a data-free time if we don't know how this is unfolding and for everyone. So we are very much trying to adapt to the ongoing conditions, both socioeconomic conditions as well as formal policies and just how everyday life is changing. So we are very much trying to adapt each of the follow-ups to be reflective of this very fluid and dynamic and unexpected situation.
Yeah, and more broadly, I think it's really interesting to think about how the pandemic is affecting what we do in primary data collection and how we collect primary data in population research. And is this going to really change going forward? You know, doing this online was really sort of the only feasible low-cost way to enroll the cohort and actually get baseline data in those key early months of the pandemic. And I think as digital technology and as the internet continues to have greater prevalence of use in the population, are we just going to see more use of online methods? I don't know. And I'm interested and excited to see advances in methodologies for accounting for online-based recruitment and things like Snowball recruitment. So, you know, from a methods perspective and how we do research and, you know, like a mid-pandemic and post-pandemic era, I think it's really interesting and important to think about.
And one other thing that came to mind as well is we're also learning from participants themselves, and we're fortunate to have a very engaged group of Snowball participants who often email us or write us notes at the end of the survey and follow-up questionnaires. So we are also adapting questions given people's own, what they write to us about their lives and experiences, to help better kind of capture their own, you know, how they're surviving through this time.
Yeah, so we, in our newsletter that went out last month, we told the participants about this talk and gave the link to the ISR website. So if any of the participants are on this call, thank you for being here and thank you for being part of the study. And please keep writing to us and telling us about your experiences. It's really valuable and we appreciate it. It's really all going towards you know, informing our knowledge of what's happening during the pandemic and hopefully ultimately informing policy. So thank you.
And I want to jump in and answer this final question, which is what would happen if you sent the questionnaire to the respondents of the Detroit study. I don't know if you've been comparing notes with them. In fact, there is a lot of overlap in the kinds of things they asked about the impact of COVID and the questions you're asking, and hopefully you guys can compare notes a bit.
Yeah, I think that's a really important question, and I think we should be comparing our results. We do have, Michigan is somewhat overrepresented in our sample, I think because we recruited through the U of M health research database and probably just the way the snowballing worked out. And so it will be really interesting. I don't know specifically how many are from Detroit versus other parts of Michigan, but I think that we should compare results with theirs. I think it'll be really, really important. And I think, yeah.
Yeah, and we did also try and harmonize some questions with other studies in that. So for example, we asked, how has COVID-19 affected your rates of saving, spending, or, you know, use of public assistance, as well as your chance of running out of money, which if I remember correctly was in the Detroit study. So we do hope to be able to compare. Again, we have both national representation, but we also do have a fairly large Michigan representation as well. So compare experiences across the state too, to see areas of vulnerability and risk from COVID-19.
Well, that's great, and I'll put in a plug that, as you'll hear in some of the upcoming presentations, if you attend them all, some of our other studies, like the health and retirement study, have also been putting questions like this, and there's a lot of overlap, so hopefully we'll be learning a lot about this, including with the focus on the older population. So we're running out of time. Let me just thank Jessica and Lindsay for a fantastic presentation. Unfortunately, everybody can't clap. We had well over 120 people. I lost track of keeping track of when it hit a peak, but fantastic to have such a great crowd here. It's a great project, amazing to have such fast results, really important results, and you've done a great job and you gave great presentation. Thanks everybody for joining us. We'll have another installment in our series 2 weeks from now, so watch for updates about that. Remember that the video from this presentation and from our previous 3 presentations will be available on the ISR website. So thanks everybody for coming. Thanks to Jessica and Lindsay for a great presentation, and everybody stay safe. Thank you.
Thank you.
Thank you so much, everyone. Have a great day.
Bye.